Hello. Let's talk about heart failure. It's defined in this text as a syndrome manifesting as the inability of the heart to fill with or eject blood at a rate sufficient to meet the metabolic demands of the tissues due to structural or functional cardiac conditions. So, what does that mean? It means you got a low cardiac output. And normally, whenever your heart feels that its cardiac output is dropping, or whenever the cardiac output is not sufficient to meet demands of the body, right? Then your heart's going to act in a manner to raise its cardiac output. So that's normal. You do that every day of your life. Heart failure is the inability to compensate for an increased oxygen demand by increasing cardiac output. So I want to break down that term compensation. It's a really important verb. It means to work to counteract a stress. And another way to look at compensation or to compensate, what does it mean to compensate? It basically means to maintain homeostasis around a defined point. And cells compensate, and tissues compensate, and your body compensates, and you psychologically compensate. So this is a very useful verb to compensate, to work to counteract a stress, because it can be applied across living systems at different magnitudes of size. And at the case of the cell, the stress is oxygen demand. And then that's at the case of the tissue too, right? You need oxygen to make ATP to sustain life. And how do your tissues get oxygen? Well, the heart pumps and it sends blood, which contains oxygen, all throughout your body, and it perfuses these tissues. So if the stress is oxygen demand, then to compensate, to counteract the stress of oxygen demand, essentially means to raise your cardiac output. So that's how we're looking at heart failure and compensation. And mechanisms of compensation, there are three basic ways by which your heart does this. It's going to beat faster, it's going to fill itself with more blood, so more preload, or it's going to increase its own contractility or inotropy. And there are various mechanisms by which the heart can do this. And one of them is the Frank-Starling mechanism, which states that the more blood you put into the heart, the stronger the heart's going to pump to get that blood out. So more preload equals more stroke volume. And that's what this graph is showing us here. We've got preload on the x-axis and stroke volume on the y-axis. And we see that in a normal healthy heart, the blue line, when preload goes up, stroke volume's also going up, right? But then in the case of heart failure, well, when preload goes up, stroke volume goes up, because you can still compensate with a failing heart, but your ability to compensate is lessened. And so what that means is that given a certain preload, with a normal heart, you've got a healthy, normal stroke volume. But with a failing heart, this big red dot here, you see that your stroke volume is way down, and that reflects a failure in compensatory mechanisms. So this snowballs and snowballs and snowballs, and eventually you run out of stroke volume, right? Because it doesn't matter how much preload you put into the heart, because it can't squeeze enough or fill up enough. It doesn't matter how much preload is coming in. Your stroke volume's down. And so because we know that cardiac output is stroke volume's a factor in that, that means your cardiac output is down. And that means that all of the tissues of your body are going to be receiving less blood, and thus the stress of oxygen demand globally throughout your body is not being compensated for in the case of heart failure. So clinically, how does this present? Well, when you're compensated, you see things like tachycardia, again, high heart rate, because that's how the heart increases cardiac output. You see high catecholamine levels, because that's how your body's increasing volume of blood to try to increase preload to increase cardiac output. And so all of the manifestations of a compensated heart failure are indicative of this increased cardiac output, compared to a decompensated heart failure, which is characterized by a cardiac output that just falls off a cliff. And we call this shock. And a fancy word for shock is hypoperfusion, because that means that not enough blood is getting to your end organs. And in a general sense, this is hypotension or a low blood pressure. And so whenever your patient's blood pressure starts to drop, and they have heart failure, that's an immediate sign that they are decompensating. And the most common cause of decompensation is an acute MI, because again, that's an acute injury to the muscle of the heart that's going to prevent it from contracting strongly enough to maintain cardiac output. So then we reach this section titled Pathophysiologic Compensatory Mechanisms. And what that means is basically ways that your body maintains cardiac output. Because remember, compensation means keeping a high cardiac output, and decompensation means letting your cardiac output drop. So the section's telling you compensatory mechanisms, ways that your body keeps cardiac output high. And it lists 4 of them right here at the top. The Frank-Starling mechanism, more preload equals more stroke volume. Cardiac remodeling, and that goes hand in hand with myocardial hypertrophy. And remodeling is specifically throwing down collagen to maintain the integrity of the heart in the face of an increased stress. And then hypertrophy is the same process, well, kind of the same result, but in your myocardial cells, in your muscle cells rather than your fibroblasts. So the muscle of your heart swells so that it can pump with a greater force in the case of a pressure overload, or it will hypertrophy in a different direction. It'll hypertrophy outwards in the case of a volume overload. And then finally, mentioning neurohumoral systems. What that means is that you can raise your blood volume through various mechanisms if you need to in a pinch. And this increase in blood volume is going to result in an increase in stroke volume, increase in cardiac output. So that's what neurohumoral systems means. It means that your brain is going to recognize that your cardiac output is low, and so it's going to send signals down your nervous system to certain tissues, but especially your adrenal glands and your kidneys, to release things like catecholamines and renin so that you can raise your blood pressure. And so then that's what the next page or so talks about. Frank-Starling mechanism again, volume in, more stroke volume out. And this is normal physiological compensation. You ought to be able to do this properly. But cardiac remodeling is going to interfere with the Frank-Starling mechanism, because Frank-Starling mechanism assumes a very compliant and stretchable heart, right? And it assumes that the heart can contract and snap back into place in a healthy manner too. And if you throw down a lot of collagen, or if the myocytes of your heart start to swell up, well, then their ability to perform the Frank-Starling mechanism gets diminished. And that's what this graph is showing you right here. Frank-Starling mechanism normal, Frank-Starling in heart failure. You can't do Frank-Starling as well, so you can't snap back with the same preload. The following changes are referred to as remodeling. Cardiac mass increases as a result of myocyte hypertrophy and ventricular wall thickening, which help to maintain ejection performance. So this is your concentric hypertrophy, concentric meaning towards the center, and this is going to be your preserved ejection fraction heart failure. And remodeling also involves eccentric hypertrophy sometimes, which is due to a volume overload and is associated with a thinning of the walls of the heart. And this is going to increase the diameter of the lumen of the ventricle so that it can fit more volume into it. And then if you look down with the microscope, what's happening to these myocytes during hypertrophy? Well, they're swelling, they're getting larger, and they're also throwing down some fibrous collagen type tissue in between them to help hold them together as they get larger, because you need a greater force to connect bodies of greater weight or mass. And then finally, you might see some apoptosis within cardiac muscle, especially as this hypertrophy progresses to a severe degree, because it's associated with lots of generalized inflammation and lots of catecholamines too, and lots of angiotensin converting enzyme and angiotensin 2. And that's going to lead to muscle apoptosis in the heart. We're going to see that real quick. So physiologic remodeling basically means this is normal up to a certain point. Hypertrophy is normal when it's in a certain way in response to certain stresses. But pathologic remodeling is going to occur in response to pathologies, things that go wrong. And so lots of different things that can go wrong. I'm not going to get into those. Point is, they lead back to this decrease in cardiac output, right? And if it gets severe enough, then that's going to be decompensation. And the remodeling is an attempt to raise cardiac output. Then it talks about some neurohumoral remodeling mechanisms. Again, this is local production of angiotensin II, norepinephrine, and endothelin. And this is pretty important because angiotensin II is specifically going to tell your heart muscle to commit apoptosis. And then norepinephrine is going to increase the surface concentration of apoptotic receptors, ligand receptors on the surface of cardiac muscle. And then these two molecules are also going to stimulate collagen synthesis by myocytes, leading to a fibrosis and a proliferation of the extracellular matrix. So if your extracellular matrix becomes too dense, the heart can't stretch enough, right? So that's your diastolic dysfunction there. And then also it's not going to be able to contract as quickly. It's going to be less inotropic. And so that's going to feed into your systolic dysfunction. So the throwing down of collagen in between myocytes leads to both systolic and diastolic dysfunction. And which way it swings, it can be both, remember, but which way it goes first is going to be determined by whether the overriding concern is a pressure or a volume overload. And so that's what this last paragraph here in this section talks about, is that a systolic dysfunction is an eccentric hypertrophy with a reduced ejection fraction, and it's attributable to largely a volume overload, but it's important to note that even a pure pressure overload will lead to systolic dysfunction if given enough time. And then diastolic dysfunction, which if you see only this first, well, then that means that there's the pressure overload component of this heart failure is way greater than the volume overload component. And you see this specifically in cases of restrictive cardiomyopathy, constrictive pericarditis, lots of other SDLs on this particular test. So now we start to look at what's going on at the cellular level during hypertrophy. And hypertrophy, hyper meaning too much, trophy meaning growth relatively. You can tell in these two images that on the right side, these myocytes are a little bit thicker. Just if you take their radius, right, compared to like one of these really thin ones up here, you know. This one's pretty thick too right there. Like that's a big thick bundle down there at the bottom. And then again, looking at this left side here, that's normal. That width or diameter of these muscle fibers. Notice they're a lot thinner on the left here than they are on the right. And then this big nucleus here on the right, that's a hypertrophy nucleus. It's swollen, it's enlarged, it's engorged, and you're able to easily identify that under a microscope. And of further note is this sort of spider web looking connective tissue in between cells. You notice that cells are a little bit more frayed or a little bit more spread out, pushed apart from the inside almost. Again, if we zoom in, you can really tell the fraying or the thinning of specific regions of myocardium in this hypertrophic slide versus how dense it is. Look, you can tell that that's a plump cell. That's not a cell that's falling apart at the seams, right? So that's the differentiation between a normal and a hypertrophic slide of myocardium. And remember that hypertrophy can be physiologic as well in the athlete's heart. But if they're not an athlete, it's probably not a physiologic hypertrophy. And hypertrophy is going to be characterized by obviously increased protein synthesis, because how do you get bigger if you're not making proteins? And then more mitochondria as well, to be able to efficiently metabolize energy, because you need to be able to be in an energy surplus in order to grow. And so the mitochondria reflect your cell realizing at the DNA level, hey, I need to make more of this stuff if I have any chance of growing, because with more mitochondria comes more ATP. And all of this is upregulated at the nuclear level. It's quite fascinating. We talk about different types of hypertrophies. Concentric, meaning with the center or towards the center, and then eccentric, meaning out from the center or away from the center. And that's how you're going to remember the hypertrophies if you see a gross axial section of a heart. Again, it can be a combination of both. It's important to remember at this section of the SDL that this is referring to systolic and diastolic heart failure, and that is not the same as left and right heart failure. A considerably more severe cardiac hypertrophy is generated in volume overload. Again, volume overload is going to be largely the eccentric hypertrophy at the bottom here. And the reason why it's going to be more severe is because this is your reduced ejection fraction hypertrophy, or your HFrEF. And so whenever you can't keep up your ejection fraction, well, the problem of low cardiac output is going to compound and snowball a lot quicker than if your ejection fraction is preserved, as is the case in a concentric hypertrophy. So then we move into this section titled Peculiar Characteristics of Cardiac Hypertrophy. And again, we're remembering that hypertrophy is one compensation mechanism of a few, and that hypertrophy reflects that the heart's not pumping hard enough to meet oxygen demands. So in order to meet oxygen demands and keep a high cardiac output, it has to hypertrophy so it can squeeze with more force or accommodate more blood. So this section of the SDL, this couple of pages, I could see a test question coming from here. It's feasible just because there's 8 bullet points here, so there is just a wealth of material. And I can see the sort of question being, well, you could get shown a picture of a hypertrophied heart, be it gross or histological, and then you might get asked, well, what do you expect to see systemically? And then you would have to say, well, okay, increased catecholamines. And then it could ask you, like, maybe it could describe a patient with heart failure and not show you the hypertrophied heart. And then the question would be something like, what do you expect to see inside the heart of this patient? And then you would have to answer with interstitial fibrosis, or a shift in gene expression, or increased apoptosis of myocardial cells, or increased growth factor signaling, right? Or something like that. So that's the sort of question I see coming out of these 2 pages. Running through the material quickly, bullets 1 and 2 are telling you what you're going to see on histology. It's telling you that you're going to see big cells and big nuclei, but you're not going to see a proliferation of blood vessels inside a hypertrophied heart. So if you do see blood vessels on a slide, know that it's going to be something that's more reactive to injury, such as an endocarditis, myocarditis, something like that, something inflammatory, quite usually, or maybe even post-MI. But if it's just normal hypertrophy, you're not going to see capillary investiture. And then finally, hypertrophy is associated with interstitial fibrosis. This is going to be something that you do see on a histology slide, so it's fair game to ask you, like, or include it in some sort of question about what do you expect to see in a hypertrophied heart on a slide. And it's going to be due to TGF beta encouraging M2 macrophages to do their thing and lay down collagen. And then smooth muscles also have the potential to lay down collagen in response to the proper stimulating factors, of which angiotensin 2 is one. And this fibrosis is going to interfere with relaxation, and it's going to impair the diffusion of oxygen into the myocardium from your coronary arterioles and capillaries. And again, it's only going to snowball once this fibrosis gets worse. And then we talk about the shift in gene expression, and this is going back to the concept that your heart, cells of your heart can tell that they're not meeting your oxygen demand sufficiently. And they can tell this because your brain is like, okay, I'm hypoperfused. There's a low cardiac output. What can I put into the blood to tell the heart that it needs to pick up the pace? And that's your neurohormonal control of the heart. And the brain is going to be where the signaling starts. And so it's going to tell your adrenals to make catecholamines, right? And then it's going to tell your kidneys to make renin. And then it's going to tell your heart to make atrial natriuretic factor, because the brain itself is going to make BNP, brain natriuretic protein. And both of these are going to work to modulate water. And in the compensatory sense, well, when there's a hypertrophy, you specifically make ANF and BNP in order to reduce the volume load on the heart. And I want to walk back a little bit and clarify a few things. You shouldn't be making atrial natriuretic factor and renin at the same time. Those are opposite axes, right? Hormonally speaking. Atrial natriuretic factor, what does natriuretic mean? Well, the natri means sodium, and the uretic means urine. And so atrial natriuretic factor means that it's making you pee out sodium, which is the opposite of what renin does. Renin raises your blood pressure, so it conserves sodium. That's what that axis does. So anytime you see ANF, BNF involved, you know that your brain is losing volume intentionally. And one of the reasons it could be losing volume is because the blood volume is creating a really high preload, which is going to increase the myocardial VO2, the oxygen demand of the heart, because we know that it has to contract harder against a greater preload. So this is the ANF and BNF expression is a mechanism by which your heart can release factors that hold that high preload in check. And then that's a compensatory mechanism. Another compensating mechanism is a switch to fetal myosin. What you need to know is that essentially this switch in myosin isotypes is going to lower the oxygen demand of the heart. Same thing that ANF and BNF is going to do. And another genetic switch that you're going to perform within the hypertrophied heart is that you're going to switch to genes that can perform glycolysis and anaerobic you're going to downregulate genes performing glycolysis and increase fatty acid oxidation genes. And no, I'm getting that backwards. Sorry about that. The failing heart reverts to using glucose because glycolytic metabolism uses less oxygen. So, okay, this stuff is so minute. I don't think it's a test question, but at least you can work through it. Hypertrophy is associated with an increased rate of apoptosis. That's of minor importance. What you need to know is that there are certain molecules floating around in the blood that when they bind to a cardiac myocyte can begin to induce apoptosis if there's enough of these molecules binding, and angiotensin 2 is one such molecule, and so is endothelin 1. And then also catecholamines in excess increase the sensitivity of myocytes to apoptotic stimuli. Autocrine and paracrine mechanisms, well, that's referring to local endocrine signaling. Endocrine is going to mean like it's released into your whole bloodstream, but autocrine means that the cell is releasing something that's immediately going to kind of boomerang back and work on itself. And then paracrine means that one cell is going to release some signaling molecules that are going to diffuse locally and work on neighboring cells. And so angiotensin 2, endothelin growth factors, those are examples of such signaling molecules, and they're going to work on fibroblasts to get them to lay down collagen. Remember, that's called remodeling, and that's why we treat remodeling in heart failure, chronic heart failure, with ACE inhibitors, because that's going to slow down the angiotensin 2 production and thus slow down the rate of remodeling in the heart. Then there's beta adrenergic desensitization. This is referring to receptor plasticity, basically, and it's the same thing that happens with caffeine, you know. And I think that understanding that the amount of receptors on the surface of any given cell is going to be proportionate to the environment that that cell lives in. And that's important because it applies to all your cells and all your tissues. And it even applies to the behavioral level, you know, like, and we call that adaptation, you know, or tolerance, you know, to different chemicals, foods, behaviors. Caffeine is a great example, you know. It's like you take a week off caffeine and then you drink that first cup of coffee and it's like, oh, you're through the roof, right? But then a month later and it's like you need 3 cups to feel like a person, and it's just like, man, it's like you are tolerant to that. And so the same exact thing happens on the surface of your cells, and in your heart this can happen in response to catecholamines. And so what this means is that you can put out all the epinephrine that you want into the bloodstream, but it's not going to do anything to the heart because it's not got enough adrenergic receptors to be able to bind. And this is also the same thing that happens in insulin insensitivity or desensitization. That's seen in metabolic syndrome, and that's seen also sometimes in type 2 diabetes. So what you're going to see then to compensate for the beta adrenergic desensitization accompanying hypertrophy is that your adrenals are going to throw catecholamines into the blood, and you're going to be throwing all the norepinephrine in the world at your heart, and it's not going to be responding. And so the symptoms associated with high epinephrine, meaning vasoconstriction, so high blood pressure, maybe anxiety too, and stress, generalized symptoms, those are going to apply here. Then finally, calcium homeostasis defects. This is the last peculiar characteristic of hypertrophy we're going to talk about. Whenever your heart hypertrophies, then the efficiency of several inotropic related proteins, which are going to have to do with the release of calcium into the cytosol to get your cell to contract, those proteins are going to become downregulated with hypertrophy. And so this is going to lead to a decrease in intracellular calcium, which is going to further exacerbate the fact that your heart is lacking in contractility. So that's most of the frustrating kind of textbook style material for this lecture out of the way. Let's get into the cool stuff, which is the clinical applications. At autopsy, if your patient's got heart failure, they're going to have a big heart, period. And that's because it's hypertrophied, and we've covered hypertrophic mechanisms in the last 10 minutes or so. Let's talk about left side heart failure. We're going to be talking about left side and right side heart failure, right? And left-sided heart failure is a forward failure. And that means that you're having problems pumping blood out of your heart into circulation. So you have a low cardiac output because you just can't pump hard enough. And left-sided heart failure is always going to be pulmonary edema. Pulmonary edema is always going to mean the left side of the heart is failing. If it's exclusively a right-sided heart failure, you're probably not going to see pulmonary edema. And then finally, cardiac output is going to be through the floor. It's going to be so far down. because your left side pumps out to the system. So you're going to see left-sided heart failure. I would say that this kind of cluster of 4 specific pathologies is really useful to know. Really, really useful to know. Ischemic heart disease, hypertension, both of those are going to give you a left-sided heart failure. But for this test specifically, aortic and mitral, so left-sided valvular diseases. Doesn't matter if it's a stenosis or regurgitation, doesn't matter, aortic or mitral valve. If it's a valve on the left side of the heart and it's broken, it's going to give you left-sided heart failure if unrepaired. And then finally, myocardial diseases. There are a few of those. They can be infectious in nature, or they can be acquired, or they can be genetic, as in the case in some myopathies. So big takeaway is that valve diseases and myopathies and infectious agents are going to cause left-sided heart failure. The major clinical effects stem from congestion of the pulmonary circulation. The lungs are going to be volume overloaded if the left side isn't pumping efficiently. And then you're also going to see a slowing down of flow in the left side if it's not keeping that cardiac output up. And this is a stasis of blood, and this encourages clotting, which can lead to the formation of a wall thrombus in your atrium or even on your ventricle if some of the tissue is damaged. And then that thrombus can get dislodged, especially in the case of atrial fibrillation, and then that can float downstream and occlude a specific artery in your brain or your kidney or wherever. And so the stroke risk associated with thromboembolism is also pretty particular to the left heart being damaged, because if it's your right heart, well, then those emboli are going to go into the lungs 99.5% of the time, except for in the case of a paradoxical embolus. But right side, you're getting pulmonary embolisms. Left side, you're getting systemic embolisms. And again, this is all going back to a decreased cardiac output. Heart failure means cardiac output's going down, and you can compensate for this by raising cardiac output, again, by raising preload or raising heart rate or raising contractility. And then when you can no longer do those 3 things, you're going to decompensate, and then it's all downhill. And thrombus formation, this mentions a minor point here. The text mentions the atrial appendage. I want you to know that the atrial appendage is another word for the auricle, which is basically a pocket of tissue inside your atria, kind of analogous to, like, if you've ever had your wisdom tooth out, remember feeling around with your tongue and feeling that pit where your tooth used to be. Well, your auricle on the inside of your atria is a pit like that. It's a dead end and a cul-de-sac. And because it's a dead end, what that means is that blood can just get in there and sit for a minute, And when blood sits, that's stasis, and that's part of Virchow's triad, and that encourages clotting, which AFib is going to dislodge that clot, and that's how you get the stroke. So the atrial appendage, or the auricle, is a significant site of thrombus formation. Now let's start talking about the lungs. So we said that lung involvement is really characteristic of left side heart failure. And you get this pulmonary edema, and the reason why you get a pulmonary edema goes back to Starling's forces. Remember, you've got a hydrostatic pressure and an osmotic pressure inside your bloodstream. And then outside of your bloodstream in your tissue bed, you've also got a hydrostatic pressure there and an osmotic pressure there. And your hydrostatic pressure, whether it's in a capillary or a tissue bed, is basically the strength or the force with which fluid is pressing against the wall of the blood vessel, separating these 2 compartments. And then osmotic pressure, that's not a push. Osmotic pressure is a pull, because proteins have a pull of water because they're polar, and water loves polar things. And so water will just get all up in between the spaces, the amino acids of a protein, and make itself right at home. So that's why proteins have a pull, and they're also charged too, just like how sodium is charged, and you know that water follows salt. So the same thing is happening with proteins, and that's your osmotic pressure. So the concentration of proteins in a given compartment is the osmotic pressure of that compartment, or the pull of water into the compartment due to the presence of proteins within. And so normally your osmotic pressure inside your blood is higher than your hydrostatic pressure. So what does that mean? Net, that means that there's more net water coming in than net water being pushed out. The high osmotic pressure normally means there's more water being pulled into the capillary than is being pushed out. And that makes a lot of sense. Because if it were the other way around, well, you wouldn't have any capillaries at all, you know? You'd just be one big bag of interstitial fluid. And some cells are like that, you know, some multi-celled organisms are like that, but we're not like that. And plants aren't like that, and animals aren't like that. They have a macro structure that's enabled by the fact that they're carrying pressurized fluid within their pipes. It's got pressure to it, you know, and so how does the fluid stay in those pipes? Because if they're leaky because of endothelium, then you would think that, well, the fluid would just dissolve on out, diffuse on out through the walls of any blood vessel it came across. And you're right about that. But the answer as to why fluid stays in your blood is because there's more protein in your blood than there is outside your bloodstream. That's what makes fluid stay in your bloodstream. So whenever there's a volume overload in a particular region of vasculature, that huge volume is accompanied by vasodilation that reflects the strong hydrostatic pressure of that fluid in that locality. And the hydrostatic pressure is going to be pushing fluid through the walls of these capillaries and into the tissue bed of whatever organ has the high hydrostatic pressure. And in the case of left heart failure, the volume backs up into the lungs. There's your high hydrostatic pressure. That's how you get your pulmonary edema. So here is a left heart that's been volume overloaded. We know it's been volume overloaded because the lumen's pretty wide and the wall of the heart is starting to thin a little bit. And so we call this an eccentric hypertrophy. And this is also going to be called a systolic dysfunction. And this is also going to be called a HFrEF, heart failure with reduced ejection fraction. And so then what we're looking at on the left here is your lungs, and specifically your alveoli, which is kind of the interface between air and your body. And it's a really cavernous and bubbly sort of looking tissue, but because it's all dark and filled in, we can tell that there's some fluid inside these tissues. And specifically, you see a lot of these dark hemosiderin-laden macrophages too. And hemosiderin is a byproduct of iron. Well, we know heme means iron. So anything that's got hemosiderin in it has a lot of iron in it. So where did these macrophages get the iron? Well, you started bleeding into your lungs. And there's a lot of macrophages in your lungs, ton of them there. And that should make sense, right? Because, I mean, you're constantly breathing in, and so you're constantly exposing yourself to pathogens and contaminants and dust and particulate matter from the outside world. And so you have to be able to process that and chew it up before it gets into your bloodstream, because you don't want sepsis from something that you breathe in. So you have a ton of macrophages in the lungs, and so they're there to clean up the blood cells that can leak whenever your capillaries in your lungs get leaky because they're volume overloaded. And systemically, this is going to manifest as fluid out the nose. Again, that's an acute pulmonary crisis. And that can be due to anything that's going to give you an immediate volume overload. So maybe if your patient goes into acute kidney failure or liver failure, well, then what's going to happen to their osmotic pressure? Well, if they go into liver failure, your liver makes proteins, and so that's going to go down. And if they go into kidney failure, well, then you're not going to be peeing as much, and so you're going to be retaining volume. And so actually in liver failure, you're going to be making more proteins because your liver's splitting apart, right, and releasing all these ALTs, ASTs into the blood, the transaminases. And so you've got all those proteins in your blood, and they're going to pull water into your blood, and that the blood's going to get to your lungs, and there's your volume overload there. So if your system goes volume overload really, really quickly, your lungs can be the first organs to manifest change or damage when you've got left heart failure. So the fluid foam coming out the mouth or nose, very characteristic of acute pulmonary edema. Again, grossly, you see fluid on the surface of the lungs, and that's there because there's a high hydrostatic pressure, just literally pushing that fluid into the parenchyma. And then here on the right, we see proteinaceous fluid in the alveolar spaces. Pretty obvious. Again, here at the bottom of page 9, talking about how some red cells get pushed into the lungs by high hydrostatic pressure, and macrophages eat them up, and they store they store the iron as hemosiderin. And so that's why your patients are going to be coughing up blood in such a case. And you could also see it as rust-colored sputum, red-tinged sputum. This is in your differential heart failure and high hydrostatic pressure leading to pulmonary edema. Then a couple more characteristic findings. Curly bee lines, I believe, are important to know. That's a curly bee line. And then bat wings, kind of hard to see at first, but then they've got this shape that is kind of indeed like bat or butterfly wings. And it's vague, it's hazy, but you can say with certainty, well, there aren't any bat wings here, really. I mean, they're kind of minor, but this is all good to keep in mind because where are we going after we finish the heart? The lungs. So start getting used to it. So let's talk about right side heart failure now. Remember, we said that the left side, whenever the left side of the heart fails, that's going to manifest as a pulmonary edema and pulmonary symptoms, and also symptoms of low cardiac output, such as fatigue, dizziness, headache, hypoperfusion, maybe end organ failure if it's the kidneys especially, and then associated risk of clotting, systemic clotting, and stroke. The thromboembolism gets up to your brain or kidneys. That's left side. Now we're going into the right side. Right-sided heart failure is a backward failure, and that means that your heart can't fill up with enough blood on the right side, so volume is going to back up into your venous circulation, down your inferior vena cava, especially due to gravity. And when volume backs up down your venous circulation, the first place that affects is the liver. And volume can keep going down, down, down through your veins, and it can pool in your lower extremities. And when it does that, it causes what's called a pitting edema. And so we're going to get there. What you need to start with is that the systemic manifestations of right heart failure are going to be number 1, edema, and then number 2, liver damage. So most common cause of right side heart failure is left side heart failure. Makes sense, right? Because the left side fails, then the volume backs up into the lungs, then the volume backs up into the right side. So the right side can have a volume overload or a pressure overload, but typically it's a volume overload. And you can have this pure right-sided heart failure, which is very rare, but it's typically in patients who smoke or have an obstructive lung disease. And that's called cor pulmonale, and cor means heart, and pulm meaning lungs, right? So your heart's bad because of what's happening in your lungs. Cor pulmonale is right-sided heart failure. I have seen a couple of specific right-sided heart failure practice questions. One of them was patients got epigastric pain and increased leg swelling for 2 years. Patients got jugular venous distension, so that's a backup in the right side of the heart, right? Thoracentesis yields 500 mils of clear fluid. Thoracentesis, you're putting a needle in the thorax and drawing it out. And so in this case, the clear fluid means that there's pleural effusions. Pleural effusions is going to mean high pulmonary pressure. And so it says, what's the most likely underlying the disease? And so you got to inference, well, okay, they do have the symptoms of right heart failure and only right heart failure, epigastric pain, leg swelling, jugular venous distension. Combine that with excess fluid in the lungs, and they're essentially asking, how do you get cor pulmonale? And the answer to that is, well, it's going to be an obstructive disease that backs up fluid into the right heart. And so the right answer was chronic bronchitis, and you might be prone to put pulmonary hypertension, but pulmonary hypertension is also going to lead to a left side heart failure, and there were no symptoms in this stem indicative of left side heart failure. And then a valve stenosis, it wouldn't be a valve stenosis because of the pulmonary involvement and the right side, and so what valve is going to be stenosed? Well, if it's the mitral valve, you'd see left side, but then if it's the tricuspid valve, you're not going to see lung hypertension, right? And then acute MI, that's just foolish. These symptoms are chronic. So then we're looking at what sort of histopathology do you see in a right heart failure? And they could give you the lungs to look at and ask you to make an obstructive diagnosis. They could give you the heart, a gross section of the heart, and show you only the right side hypertrophied. They could ask you a right-sided heart failure question and only give you a slice of histology of the myocardium. And so you'd have to draw back to what we referred to on pages 4 and 5. And they could also give you a slice of the liver. And the reason they could give you a slice of the liver is because whenever the right side is volume overloaded, blood backs up into the venous system, and the liver's where it goes first. And you see this nutmeg liver. And nutmeg liver is colloquial term for centrilobular necrosis. So your liver's got lobes, and then it's got lobules, and it's essentially a nested honeycomb structure. And so nutmeg means that at the center of all these structures, there's a vein, and fluid's backing up through the vein, and fluid is pushing into the functional tissue of the liver, going backwards where it shouldn't be due to a high hydrostatic pressure, right? And so if this compounds, the liver is going to reactively throw down collagen and scar up, and that's going to lead to, in the worst case, cirrhosis, liver failure. You really need to be able to recognize nutmeg liver grossly, because to my knowledge, I'm not going to say there's nothing else that causes it, but right heart failure causes nutmeg liver the vast majority of the time. And then we're going to get into edema. And peripheral edema is the second characteristic finding of right heart failure. You're not really going to see edema if it's a pure left heart failure. It's important to know that this is a transitate. Pitting edema is a transitate. And edema means fluid where there shouldn't be. Edema is swelling. It's basic fluid accumulation. Now, normally, your capillaries are going to look like this. Boxed in green here. That's what your capillaries normally look like, in the sense that your endothelial layer is just nice and stuck together. There's no gaps in between it. And then you're going to have a lot of proteins inside the plasma of your capillaries. So we'll draw some proteins in there, right? Got a lot of proteins up in there. You get the idea. So in a transitate, you've got an imbalance of Starling's forces. In the case of a transitate, you get edema, so you get fluid in your tissues. Where's the fluid come from? Your bloodstream. How does the fluid get from your bloodstream to the tissues? And that's the difference between a pitting edema and a non-pitting edema. And that's the difference between a transitate and an exudate. How the fluid gets from the blood to the tissue. So in the case of a transitate, you've got a really high hydrostatic pressure, right? Or the alternative is you don't have a lot of proteins in your blood, meaning that you've got a low oncotic pressure in your blood. So because there's not a lot of proteins in your bloodstream, there's no pulling fluid into your bloodstream. And so the hydrostatic pressure wins. And when hydrostatic pressure wins out, the net movement of blood is out of the bloodstream into the tissue. And that's a transitant. And a transitant is a type of edema in which you don't see protein in the tissues. And that's why it's pitting, is because the transitant, the edema, doesn't have a high protein concentration, because we know that water is going to flock to protein, right? So if you have an edema that doesn't pit, that springs right back up whenever you put your thumb on it, that's how you know, oh, this is an exudate, because the proteins in that edema draw water back into it after it's depressed and make it spring back up with that pressure of the fluid that it's drawing in there. But if there's no protein inside that edema, when you press down on it, it's just going to stay depressed because it doesn't have the colloid pressure or the osmotic pressure to draw water back into that depressed area to make it spring back up again. And so thinking about the capillary level, the difference between pitting edema versus non-pitting edema is going to be the leakiness of the capillary endothelium. And when the endothelium is leaky, that's called an exudate. And I've illustrated that here with the blue arrows, demonstrating the movement of fluid in between cells. And so if you've got gaps in between your endothelial cells, then you can imagine that protein can move through these gaps in between endothelial cells. And that's exactly what protein does, is it's going to diffuse outwards in between the gaps in the endothelium and leak into interstitial space of a tissue. So that's an exudate with a high protein content. And remember, the high protein content in the tissue is what causes it to spring back up whenever you push down on it. Versus a transitate, which all the protein stays in the bloodstream. And transitate means that it's going to be a pitting edema because the protein can't leak into the tissue. Why can't it leak into the tissue? Because the endothelium is still intact. And so that's the basis of the pathogenesis of a transitate versus an exudate. Anytime you see an exudate, you know that there's been some inflammation, because that's what's going to stimulate the endothelium to vasodilate and become leaky and permeable. Versus a transitate, if you see a pitting edema, you know for a fact that the reason why the edema is there is due to either a high hydrostatic pressure or a low oncotic pressure. That's it. Because if there were any inflammation involved whatsoever, those capillaries would be dilated and thus permeable and leaky to proteins. And so the edema would not be pitting. That's the big take home. You see pitting edema, Starling's forces are involved. It's either a high hydrostatic pressure pushing fluid into the tissue, or it's a low oncotic pressure in the blood, meaning you can't pull fluid from the tissue back into the bloodstream. So in the case of a right-sided heart failure, you see pitting edema, you see transitate. Why? Two reasons. Number one, the right side's volume overloaded, which means that backs up down your veins, and so then your veins are volume overloaded. That's the high hydrostatic pressure. Number two, heart failure compounds, snowballs enough, the liver gets damaged. The liver gets damaged, what does it do? Spits proteins into the blood. But then eventually it'll just stop making proteins because it's fibrotic, right? The acute release of protein, well, that's why those are called acute phase reactants. Because when you see all that liver protein in the blood, it's acute injury. But then those get washed out and those go away. And you're left with a scarred fibrotic liver. So that's chronic liver injury. And in that setting, what's the protein albumin in your blood look like? Well, where is albumin made? The liver. And what's most of the protein in your blood? Albumin. Albumin is like 80% of your blood protein. And if your liver is not making albumin because your liver is scarred and hard as a rock due to a right heart failure, then are you going to have a high or a low protein in the blood? You're going to have a low blood protein. And so that means what's going to happen to your oncotic pressure? It's going to go down. So are you going to be pushing fluid into your capillaries or pulling fluid into your capillaries? Well, you're not going to be pulling any fluid into your capillaries. It's going to go out. It's going to go right into the tissue, and that's the pitting edema. So I really hope that I've connected those dots in a way that you can understand. Edema of the peripheral and dependent portions of the body, and especially in the ankle and pretibial edema, is a hallmark of right-sided heart failure. Why the legs? It's gravity dependent. So let's start to synthesize a more high-resolution clinical picture based on the pathophysiology we've covered thus far. You get a patient with left-sided heart failure. There's a couple symptoms that are always going to be characteristic of left heart failure, only left heart failure. Specifically, it's going to be orthopnea, paroxysmal nocturnal dyspnea. Those two things, you really need to know what they are. So I'm going to go through this methodically and break down all these symptoms one by one. There's dyspnea. That's a shortness of breath. It can be exertional or it can be at rest. And an orthopnea is a dyspnea when you're lying down, but then when you stand up, kind of like an orthostatic hypotension, same concept there. You go from sitting to standing. Well, in this case, whenever you stand up, you can breathe better. But whenever you lay down, it gets really hard to breathe. So it's kind of the opposite of orthostatic. So that's your dyspnea and orthopnea. And dyspnea is a very nonspecific finding, but when we're talking about the heart, dyspnea means that the lungs are volume overloaded. So there's a high hydrostatic pressure in your pulmonary circuit pushing edema out into your lungs. That's where the dyspnea comes from. The orthopnea, remember, is harder to breathe when I'm laying down, easier to breathe when I'm standing up. And the reason for that is because the lungs are volume overloaded. So when you stand up, what's happening to your preload? It's going down because blood's pooling in your lower extremities. And then when you lie down, what's happening to your preload? It's going up. That's more return to the heart, more venous return. So these patients with orthopnea, they're going to sleep propped up against a pillow. They're not going to sleep flat. They're going to sleep like that. They're going to sleep like they're sitting in a chair practically, because by doing so, by putting pillows behind them, they're propping themselves up and getting more vertical, and they're simulating gravity. So that's your pillow orthopnea. These patients sit upright to reduce the preload on their heart, and that helps them breathe better. And it can be a 1, 2, 3 pillow orthopnea. We had a question stem on a previous test that said a 2 pillow orthopnea, and that's basically a grade or a measure of how far along their lung dysfunction is progressing as a result of their heart failure. So again, orthopnea is on the left side of the heart only. And then if we know dyspnea is shortness of breath, well then a nocturnal dyspnea is going to be a shortness of breath at nighttime. And paroxysmal is an interesting word that means generally the same as episodic, or kind of like spasmodic, meaning it'll occur like there and then it's gone, and then there and then it's gone. And it'll occur in this episodic manner at nighttime, this shortness of breath. So patients will wake up in the middle of the night and they'll have this tremendous anxiety, and for a good reason too, because they were probably just, not breathing for like 10 minutes. And that's enough to get your heart beating, and suffocation too is a concern. And so the patient's going to report this to you when you take a good history, and you're going to connect the dots and say paroxysmal nocturnal dyspnea, left heart failure leading to pulmonary volume overload, leading to pulmonary edema, and that's the dyspnea. Acute pulmonary edema. Acute. Okay, so acute is the key word here because we've been talking about pulmonary edema, but I want to walk through the progression of dyspnea or shortness of breath. So The first thing that happens is you volume overload the lungs. The second thing that happens is that these things called J receptors, just remember that term. You're going to see it in a few weeks when we get to the lungs. These J receptors recognize that there is fluid in the lungs, and so they're going to activate your vagal nerve, and this is called the J reflex. And the fluid in the lungs is associated with a hypoxia of sorts, and so to correct that, you breathe faster. And so this J reflex, which gets started by the presence of fluid in the lungs, is what tells you to breathe faster. And that's what causes a tachypnea, right? And tachypnea is going to be fast breathing. So that's where the shortness of breath can come from, because remember that as heart rate goes up, eventually you reach a heart rate that's so high that your stroke volume drops. Well, your lungs are kind of the same way. Eventually you reach a respiratory rate that's so high that your oxygen perfusion starts to drop. And so that's where the shortness of breath can present alongside the rapid breathing rate. Acute pulmonary edema, again, anything that causes a volume overload and exacerbates the fluid in the lungs. So an example, left heart failure, acute MI, that can cause acute pulmonary edema, and that's really life-threatening. Left-sided heart failure is going to be associated with a decreased cardiac output. We know that. That makes sense. So what does that do to your kidneys? Decreased perfusion. So what do your kidneys do when they don't get enough oxygen? Oh, they start making renin because they think that you're hypovolemic. But really, when they start popping off renin, that's just going to make your pulmonary edema worse with time. So I did see a practice question describing paroxysmal nocturnal dyspnea. Patient sleeps better while sitting up in bed. Characteristic history. Brain natriuretic peptide is elevated. What does that mean? It means the patient's volume overloaded, because a natriuretic peptide is one that makes you pee out sodium. That's what natriuretic means. So when that's high, that means that your brain recognizes that there's too much volume in your blood. And so it's correcting your blood volume by releasing brain natriuretic peptide. And so it's asking what cardiac disease best explains the condition. So which one of these is associated with a high preload, high cardiac output, increased blood volume? And the answer to that was actually a rheumatic valvulitis, right? Because we know that rheumatic fever, rheumatic heart failure following rheumatic fever can affect the aortic valve, and specifically it can cause an aortic stenosis. And so this is going to cause a drop in blood pressure, which is going to cause this reactive renal release of renin to boost your blood pressure. And when you've got too much renin, your blood pressure goes too high. And so the compensation for that is to make BNP and ANP, also known as BNF and ANF, same things. The point is natriuresis, pee out sodium. Why would blood volume be too high? And you can walk it on back to the start and inference, oh, there's a valve problem. So don't get thrown out of proportion if you see general answer choices that may or may not make sense. No, you know it, just think it through. And then the whole renin thing. So renin compensates for low blood volume, and then that's why our number one treatment of heart failure is going to be, our number one non-pharmacologic treatment is going to be don't eat salt, don't drink too much water, because we want to reduce the preload on the heart to reduce its oxygen consumption. Now getting back into the concept of systolic and diastolic failure. Well, this paragraph's really about diastolic failure. In diastolic failure, cardiac output is relatively preserved at rest. but the left ventricle is abnormally stiff or restricted in its ability to relax during diastole. So because the left ventricle can't fill properly with volume, any increase in preload gets referred back to the lungs. And this can produce flash pulmonary edema, acute rapid onset pulmonary edema, which could be life-threatening. So when the patient's got diastolic failure, that means that their heart can't stretch to accommodate blood, right? So anything that acutely increases preload is going to cause volume to back up into the lungs because the left heart can't clear it fast enough. So how could a kidney failure cause an acute increase in preload? Well, if you can't put ions into your urine, you can't pull water into your urine, so you're not going to pee as much, and so all that volume is stuck in your blood. So acute renal failure can lead to acute pulmonary failure here. Liver failure, again, in an acute liver injury, then it's going to release a lot of proteins into the blood, which is going to pull fluid out from your interstitial fluid and into the bloodstream. And then if that happens all at once, that gets into your lungs. That's a hypervolemic episode because your left heart can't clear it. Hypertensive crisis. Blood pressure is way too high. Maybe they've got way too much salt in there. A hypertensive crisis is going to result in an elevated afterload, which is going to make it even harder for that left ventricle to pump. And so that's a volume overload. If your patient's got a 200 over a 140 or something like that, you think that's a high volume? Yeah, you bet. Anxiety. How can an anxiety cause a high preload? Sympathetic activation. Same thing for hypertensive crisis, right? Alpha-1 activity, vasoconstriction, because of all the salt in the blood, if it's salt related, salt makes capillaries constrict. That happens all over your bodies. Then peripheral resistance goes way up. Venous return goes way up. That's an increased preload. Anxiety, again, like maybe an acute threat, something related to a spike in epinephrine release. Where's it going to bind to? Alpha-1 receptors. What's that going to do? Increase return to your heart. Is that an increased preload? Yeah. Could that lead to lung failure if your left heart is not working? Yes, specifically with a diastolic dysfunction. Heck, even with a systolic function. Anytime the left heart's not working, high preload is going to lead to lung failure, can lead to lung failure. If you get an arrhythmia, if your heart misses a beat, do you think you're going to have a high preload on the next beat? Yeah, I think so. What about a regurgitation? What about a left side heart valve regurgitation? Mitral or aortic, doesn't matter. Left heart's volume overloaded. If there's a prolapse and an acute regurgitation, that's the sort of thing that could lead to a flash pulmonary edema, right? Could you get that following a myocardial infarction? Yeah. Would the prolapsed valve be localized to the region of the heart that got occluded, to the blood vessel specifically? Yeah. So if it was the anterior cusp of the mitral valve, then you're left anterior descending. That's the sort of thinking you apply to these questions. It's the sort of thinking I think I'm going to apply in real life. And then the bottom, or rather the final sentence in this paragraph is very useful. The reduction in the ability of the left ventricle to relax and fill may stem from myocardial fibrosis, such as occurs in cardiomyopathies and ischemic heart disease, infiltrative disorders associated with restrictive cardiomyopathies and amyloidosis, and restrictive pericarditis, so inability of the heart to expand because the pericardium is just fibrotic. So that's a really good sentence because that lets you know anything that is going to cause inflammatory scarring or collagen deposition is going to lead into diastolic heart failure. Public service announcement: systolic and diastolic failure can occur at the same time. It can be both. So finally, let's end with right-sided heart failure and the clinical picture thereof. You see venous congestion as a result of the right side backing up. This presents with a large liver, large spleen sometimes, especially with peripheral edema. If it's in the gut, if it's edema in the gut, we call that ascites. That's going to be in the abdominal region. They've got a big fat belly filled with fluid. Peripheral edema, again, is going to be pitting edema, and it's going to be mostly found in the ankles and calves and legs. And you're going to know it's pitting edema because you're going to stick your thumb right into it. And you're going to pull your thumb up, and then you're going to look at that indentation, and it's just not going to go down. And you're going to be waiting. And it's going to be like, a good 12 seconds later before that thing goes back up again, right? Or fills back up with fluid. And then you're going to document a +2 pitting edema bilaterally. And the pittingness of that edema is what tells you this is a transitate, not an exudate. Because if it was an exudate, there would be protein inside that edema. And so whenever I push down on it, it would just fill back up with water immediately and it wouldn't pit. But because it pits, that means there's no protein in this edema, which means that the endothelial layer of the capillaries surrounding this edema is not compromised. There's no inflammation. So the only way that this edema could have gotten inside the tissue bed is through a high hydrostatic pressure or a low oncotic pressure. And so then you're going to use your big doctor brain and you're going to say, gee, does this patient have a high hydrostatic pressure because their heart's failing? And you're going to say, yeah. And then you're going to say, well, do they have a low oncotic pressure because their liver's failing? And you're going to say, yeah. And then you're going to say, oh, that's why they have a pitting edema. Right-sided heart failure, congestion of the kidneys. And so this is kidney failure and right-sided heart failure due to venous congestion, not due to hypoperfusion. But again, you're probably going to see both at the same time. Then finally, portal congestion. That's going to be some epigastric pain, GI symptoms, right upper quadrant pain. What's in your right upper quadrant? Your liver. So GI symptoms, right side heart failure, thinking nutmeg liver, which again is this petechial-like spotting of a gross liver with these little hemorrhages of blood and blood leaking into the liver. And the failure of these little spots of tissue is secondary to a high hydrostatic pressure mediated by right heart failure. So that's all I got. Thank you very much for listening. Hope to see you again.